Talking about the Parkinson's disease. Okay, so Parkinson's disease introduction. It is the second most common age-related neurodegenerative disorder. The first or the most common one is Alzheimer's. Okay, it occurs. The mean age group of occurrence is in elderlies, that is more than 60 years. Okay. So, how do you define Parkinson's? What exactly is Parkinson's disease? So, it is a syndrome consisting of variable combination of tremor, rigidity, bradykinesia, and characteristic disturbance of gait and posture. So, basically, what we have to know that it consists of tremor, rigidity, bradykinesia, and characteristic disturbance of gait and postures. Okay. So now first we'll start with the classification. So Parkinson's disorder, we have to classify it in first as idiopathic Parkinson's disorder, then we have the secondary Parkinson's, and then the atypical Parkinson's. Okay, so idiopathic Parkinson's can be further divided into genetic and sporadic. Okay, we'll be further seeing the genetic mutations which affects the Parkinson's, which are affected in Parkinson's. Now secondary Parkinson's are drug induced, which is which is like because of classical antipsychotic drugs. There is this drug induced Parkinsonism because of decreased in dopaminergic neurons. Okay, then there is this Wilson's disease, which is related to copper metabolism. So there's this deposition of the copper into the basal ganglia, because of which there is Parkinson's disorder. Then we have toxins, MPTP toxin, carbon monoxide, and manganese toxins are responsible for secondary Parkinson's infections like Whipple's disease, post-encephalitis, then trauma like punch-drunk syndrome, which are seen in boxers, okay, liver failure, and vasculars. Vascular includes MI. Then, like MI, basically atherosclerotic lesions. Okay, now. Atypical Parkinson's means Parkinson plus syndrome. Now, Parkinson plus syndromes includes DLB, that is diffuse Lewy body dementia, then MSA, which means multi-system atrophy, then progressive supranuclear palsy, and corticobasal degeneration. So these are these four syndromes which are included in atypical Parkinson's, which are DLB, diffuse Lewy body dementia, MSA, that is multi-system atrophy, PSP, which is progressive supranuclear palsy, and CBD, that is corticobasal degeneration. So this was all about the classification. Now we'll understand about the etiopathogenesis of Parkinson's disease. So there are these environmental factors and genetic factors which together play a role for development of Parkinson's disease. Now certain environmental factors which increase the risk of Parkinson's are exposure to pesticides, rural living, drinking of well water, or toxins like MPTP, which is a byproduct of heroin-like drugs. So this was all about environmental factor, which includes pesticides, rural living, drinking well water, or toxins like MPTP. Okay. Then genetic factors. Genetic factors are usually associated with young onset Parkinson's disease. So there are these mutations in gene PARK1, which is on chromosome number 4, which is for alpha-synuclein, while gene PARK2, which is on chromosome number 6, and which is for Parkin. Okay, so alpha-synuclein, Parkin, and LARC2 mutation. So alpha-synuclein, Parkin, and LARC2 mutation is responsible for further development of Parkinson's. So it is usually a two-hit hypothesis. That is, the presence of genetic factors along with the onset of environmental factor will lead to the development of Parkinson's disease. Now we'll see how it develops. Though it starts with, so there's this double hit hypothesis. After that, because of the environmental and genetic factors together, there is protein misfolding and aggregation. So there were these alpha-synuclein mutations, because of which there are protein misfolding and aggregations of these protein, which leads to formation of Lewy body, which are present in basal ganglia along with brainstem and cortex. Okay? So there are these Lewy body inclusion bodies formation. Okay? This inclusion bodies will further lead to oxidative stress, inflammations, and then which leads to mitochondrial dysfunction. So oxidative stress, inflammation, which further leads to mitochondrial dysfunction and cell death. So cell death, mitochondrial dysfunction, because of which there is progressive loss of dopaminergic neurons. in substantia nigra. We know there's this basal ganglia and there's this part, substantia nigra. So because of this increased oxidative stress and inflammation, which is caused because of protein misfolding and aggregations and inclusion bodies, there is progressive loss of dopaminergic neurons. Okay? Now, due to progressive loss of dopaminergic neuron, there is increased firing in subthalamic nucleus and GPI. We know that in substantia nigra, through the D1 fibers, there was the striatum, there was activation of direct pathway. Now, this direct pathway will be stimulating the cortex, but because of the loss of these dopaminergic neurons, there is increased firing of subthalamic nucleus and GPI, that is globus pallidus internus. This will further inhibit the thalamus, and which further inhibits the activation of cortical motor system. So it inhibits the thalamus and because of loss of dopaminergic neurons. So because of inhibition of thalamus and cortical motor system, the Parkinson symptoms appear. Okay, so this is for motor Parkinson symptoms. Now, because of mitochondrial dysfunction and cell death, there is also relative increase in acetylcholine, which leads to non-motor symptoms. Okay, so this was all about the idiopathogenesis of Parkinson's disease. Now we'll talk about clinical features. Atypical Parkinson's disease we will be studying differently. Now I'm talking about IPD, which is idiopathic Parkinson's disease. Okay, now there are these four primary manifestations of idiopathic Parkinson's disease, which includes tremor, rigidity, akinesia, and postural instability with gait abnormalities. So the mnemonic is basically TRAP, which is tremor, rigidity, akinesia, and postural instability. Okay, so we will see the timeline of the disease. So what happens before the clinical onset of disease, like 15 to 20 years before the clinical onset of disease, there are non-motor features which appears. Now non-motor features are because of alpha-synuclein depositions or alpha-synucleinopathies, that is what we say. So it consists of autonomic dysfunction and sleep disorders. In autonomic dysfunction, we have four symptoms, which is orthostatic hypotension, urinary incontinence, constipation, and erectile dysfunction. While in sleep disorders, we have again four symptoms: excessive daytime sleepiness, ineffective sleep, REM sleep disorder, behavioral disorder, and restless leg syndrome. So these are the non-motor features because of alpha-synucleinopathies, which are autonomic dysfunction and sleep disorders, which occur 15 to 20 years before the clinical onset of disease, which are orthostatic hypotension, urinary incontinence, constipation, erectile dysfunction. In sleep disorders, we have increased daytime sleepiness, REM behavioral disorders, and restless leg syndrome. Now, what are the? Now we'll talk about after the clinical onset of disease. So, in clinical onset of disease, there are these three main symptoms which will start, which is tremor, rigidity, and akinesia. Okay? Tremor. So now let's talk in detail about tremor. Like what kind of tremor? How is the tremor in Parkinson's disease? So it is an asymmetrical in onset. So first it is asymmetrical in onset, then it eventually becomes from unilateral to bilateral. Okay, it is a resting tremor of frequency 4 to 6 hertz. So the tremor is characteristic pill rolling tremor. So this is how the tremor is when the patient is resting. So pill rolling tremor appears that as if the patient is rolling some pill or something in his thumb and index finger. Okay, it starts from ipsilateral upper limb, then ipsilateral lower limb, contralateral upper limb, contralateral lower limb. So starting as asymmetrical, but eventually it becomes bilateral. Okay. Along with that, along with the characteristic pill rolling tremor, we can also see flexion extension, pronation, supination, and tremor also involves the jaw, chin, and lips. So this was all about the tremor. Takeaway point is it is resting tremor. It goes away with movements and comes again on rest or attainment of posture. It is characteristic pill rolling tremor. Talking about the rigidity, involuntary increase in muscle tone, which leads to resistance in passive movement. So like this is the passive movement without any resistance. Take it. Now, in this kind of passive movement also there is increased resistance, which leads to difficulty in performing the movement. ठीक है. So there is increase in muscle tone. This is what is known as rigidity. ठीक है. It is not velocity dependent. Spasticity is velocity dependent. Okay. Now, what are the characteristic rigidity? It is lead pipe rigidity and cogwheel rigidity. Lead pipe rigidity, stiffness throughout the range of movement. It is seen at elbow joint. While cogwheel rigidity is tremor along with rigidity. So tremor superimposed with rigidity at the wrist joint. So it is like those machines of bikes which have those two cogwheels. So how they move, like one, then stop, then one, then one. So this way they move. So that's how a cogwheel rigidity is. Tremor along with rigidity. So ratchet like jerkiness. Okay. Now, so this was about tremor, rigidity. Now we'll talk about akinesia or bradykinesia. What exactly this means? Slowness or difficulty in initiating a voluntary movement. So there's this slowness or difficulty in initiating a movement. That is what akinesia is. It is like examples are, there's this reduced arm swing on walking, then there's difficulty in walking, there's sudden freezing, Feston and Gates, short steps are taken, like increased pace of walking but short steps. Then there's this mask like faces, like no facial expression, fixity of facial expression. Okay. Then there's this glabular tap sign. So what is this glabular tap sign? So here, repetitive tapping over the glabella. So like when you repeatedly tap over what is the glabella? Between the two eyebrows, the space that we have is glabella. The repetitive tapping over the glabella in a normal person will lead to like reduced blinking. So like after some starting me, the normal person will blink, and after some time he won't blink because he will be habitual. But in case of Parkinson's disease, this doesn't happen. You keep on tapping, the person will keep on blinking. This is blink response. Okay. So this is what we tell glabular tap sign and Meosin sign. Then there's this small handwriting also in akinesia or bradykinesia. Okay. Now, so clinical onset of disease is characterized by tremor, rigidity, akinesia and bradykinesia. So this starts after 5 to 10 years. Patient starts developing postural instability. So there's this poor balance, unsteadiness and increased frequency of fall. There's this abnormal pull test. When you pull the patient, so usually we take 2 to 3 steps backward and then we get stabilized. But this person won't stabilize and he will fall. Then there's this short shuffling gait, Feston and gait, okay, and stooped posture. And after this, the further progression of the disease will lead to dementia and cognitive impairment. So this was all about the timeline of Parkinson. Before the clinical onset, 15 to 20 years before, there are these non-motor features. Then at clinical onset, we have tremor, rigidity, akinesia, and after that, we have postural instability. Now, investigation and diagnosis, that is usually clinical diagnosis. Talking about the treatment, we have non-pharmacological interventions and pharmacological. And non-pharmacological intervention is basically you have to educate the person about what kind of disease he has, what he will be or she will be suffering from, and also encourage to do some kinds of exercise, lifestyle management. Okay. Now, talking about pharmacological management. In pharmacological management, we have different classes of drugs, starting with levodopa. Levodopa is a standard drug. It's received one of the best drugs for the treatment of Parkinson's disease. So, what are these? These are dopamine precursor. So, what we do is we give levodopa along with decarboxylase inhibitors like carbidopa or benztrazide, because levodopa has increased peripheral metabolism. So because of this increased peripheral metabolism, the levodopa couldn't act. So in order to avoid that, it is given along with carbidopa to prevent peripheral metabolism. Okay? It is the most effective treatment for Parkinson's. Now, there are some kind of symptoms to which levodopa is not responsive. These include 2F and 2Ds, that is freezing phenomena, as we saw, that like short walking and then the patient suddenly freezes. And there's this increased fall because of postural instability. There's dysarthria and dysphagia. These are non-motor symptoms, sleep disorders and dementia. Okay, so the levodopa won't act on that. Now, what are the side effects of levodopa? Side effects include nausea and vomiting. Why does this occur? Because dopamine receptors are also present on area postrema, which is the nausea vomiting center, and it has no blood-brain barrier. Along with that, we also have orthostatic hypotension. Now, this was acute. Now, after the chronic use of levodopa, we have motor complications. जैसे that includes fluctuation in motor response. There's this fluctuation in motor response and involuntary movement. Involuntary movement is what we know as dyskinesia. Okay, so in motor complication we have these four things. That is pehla wearing off again. What happens is, firstly, when we used to give levodopa and starting of the disease, it used to act more than the half-life. Okay, but after the chronic use, the duration of benefit becomes shorter till it reaches the half-life. Okay, this is what is known as wearing off effect. That is, the duration of benefit is decreasing. Okay, now, so in order to tackle the wearing off effect, we have to space the drug quickly. Then there's this on and off effect. What happens is, in advanced stages of the disease, there are these on periods which are basically when the drug acts, and it is also associated with complication of dyskinesia. And there's this off period where the drug doesn't act at all. Like, it's like switching on and off the light. So when you switch off the light, there's complete darkness. Drug doesn't act at all. So there would be complete reversion back to bradykinesia, tremor, rigidity, everything. Okay. Now there's this delayed on, and then we have drug failure. So these are all about the complications of levodopa. Now dose we give is 100 is to 25 mg 2 to 4 times per day. 100 for levodopa, 25 mg for carbidopa. And dopamine agonists, that are basically pramiprazole, ropinirole, and then ergot derivatives or bromocriptine and all. So these are used in adjuvant to levodopa to reduce the off time, and they are less prone to dyskinesia. So usually, if the patient is young and there's this mild disease, so we start with dopamine agonist because it has lesser side effect and then levodopa sparing effect. Okay, but one of the major side effects of dopamine agonist is hallucination and cognitive impairment. That is neuropsychiatric manifestation. There's this impulse control disorder which leads to pathological gambling, hypersexuality, compulsive eating, and shopping. Then we have MAO-B inhibitors. So basically, there's this MAO-B enzyme which basically metabolizes the levodopa. So in order to inhibit that, it causes dopamine metabolism. So in order to inhibit that, we have MAO-B inhibitors like salicylic and rasagiline. It is used as a monotherapy in early disease, and then you add levodopa along with that. Then COMT inhibitors are basically inhibition of COM will lead to increased elimination of half-life of levodopa and increase and enhances the brain availability. So it is given along with levodopa. It decreases the off time and increases the on time. Like tolcapone and entcapone. So tolcapone has this side effect of hepatotoxicity and discoloration of urine along with cephalitis. So it is not preferred. Then we have centrally acting anticholinergic, which is basically trihexyphenidyl. Okay, trihexyphenidyl is centrally acting anticholinergic, and it is basically not given. Okay, it is not given for other things. It is given only for drug-induced Parkinson's disease. Okay, then we have this amantadine, which is basically NMDA receptor antagonist. It is used for mild Parkinson's disease, but we have side effects like libido reticularis, weight gain. Now there are these new drugs on the market, which is pimavanserin, which is basically 5-HT2 antagonist, which is being tried for Parkinson's disease. And if pharmacological management is like, if pharmacological management is not working, then what we use is surgical management. Okay, like deep brain stimulation, subthalamic nucleus is stimulated in cases of medically refractive tremor.